Hello, my name is Dr. Mary Andrew. On behalf of Women's Health Matters, I acknowledge the traditional custodians of the ACT, the Ngunnawal people, and recognise any other people with connection to the lands of the ACT and region. I acknowledge and respect their continuing culture and the contribution they make to the life of this region. This presentation is a digital version of the one I gave on 26th of July 2023 at the launch of Women's Health Matters survey report on women's health in the ACT. In this presentation, I describe the process of designing and implementing the survey, and I outline some findings and implications from the survey and our next steps. Before I do that, I'd like to acknowledge my colleagues who assisted with the project. Dr. Romy Listow, who worked on developing the project plan and did some early work on the survey design. I'd also like to acknowledge Molly Stanley and Jodie Kirkness, who worked on the logistics, communications and design. The aim of the survey was to make the state of women's health and wellbeing in the ACT visible through high-quality data. This data can then support our advocacy for gender-responsive health services and for health-supporting communities. The survey was designed to cover some key areas of women's health: general experiences of health, including mental health, experiences of using health information and health services, a deeper look at sexual and reproductive health, pregnancy and parenting, discrimination, safety and violence, and of course, the survey included a lot of demographic questions. The survey was open to women and femme-identifying people and people who align themselves with these groups, who were aged 18 years or over and living in the ACT and region. In total, 1,668 valid responses were collected, exceeding our initial target of 1,000. Thanks to our many friends and stakeholders who helped make that happen. And of course, thanks to the Snow Foundation, who funded this project, and to ACT Health for funding Women's Health Matters in general. We hope to conduct more waves of the survey in the future. We'll build on and improve the survey design and method as we go. A little about the process of designing the survey and how we went about doing it. So how did we decide what to focus on and how to word the questions? We did a big consultation process. Several people and organisations gave feedback. Thank you to those who did. We tested the survey in a focus group. Ultimately, we had to cut a lot of questions out of our initial drafts, including some on COVID-19 and some on experiences of using support services in situations of violence. You can see the survey instrument online via the QR code at the end of this presentation. This also indicates where questions were adapted from other surveys. If, as we hope, we can do more waves of the survey, we will refine it further and consider adding some of the questions in that we couldn't include, or others on a one-off or less frequent basis. So why did we do a new survey and not just use other data? It is true that there is a lot of good data already out there. For example, the ACT General Health Survey, the Australian Longitudinal Study on Women's Health, and others. Some datasets are not designed to look closely at gendered experiences of health and wellbeing, for example, the ACT's Wellbeing Framework. Some do take a gendered approach but have a different focus, for example, the YWCA of Canberra's focus on housing and homelessness. Or they have smaller numbers in the ACT, for example, the Australian Longitudinal Study on Women's Health. Through this survey, we have a large enough sample to be able to consider how different variables relate to each other. For example, how experiences of different kinds of violence might relate to experiences of health service usage. We have also been able to gather large amounts of qualitative data, people's open-ended responses to questions. Most of this analysis is yet to come over the coming months and years. A little more about the process. In terms of promoting the survey, we were able to get such a good sized sample by promoting the survey vigorously over 3 months. We offered an incentive for people to do the survey, and this incentive was a chance to win one of 2 $100 vouchers. We promoted the survey via social media and traditional media, print and radio, with support from our friends and colleagues in other community organisations and very helpful posting by ACT Health to their tens of thousands of followers. The incentives we used were effective, but they also contributed to lots of invalid responses from out of area, from bots and scammers. It required a lot of data cleaning to remove these. We're very confident the data is high quality now, and next time we'll consider other ways to minimise the workload. For data management and analysis, we used the Stata package, and we also got the presentation of the data reviewed by an ANU survey specialist. Like any survey, our survey has strengths and limitations. In terms of the strengths, we have a very large sample, which is significantly larger than the ACT General Health Survey and larger than the ACT sample of the Australian Longitudinal Study on Women's Health. We asked a lot of demographic questions about things like Aboriginal and Torres Strait Islander status, disability, cultural and language background. We found that our sample is broadly representative of the ACT community. However, we have proportionally fewer young, under 24, and older, 55 plus people than in the population generally. Our survey respondents were concentrated around the 35 to 44 year age group. We also have proportionally fewer people born overseas and speaking a language other than English as their main language or preferred language. This is a challenge with online surveys in English, and it's one we'll aim to address in future iterations, for example, through translated versions and community outreach. Another limitation is that our survey respondents self-selected to participate, and this may also reflect our networks. However, large samples give confidence, and we have a large sample. This enables stronger analysis between the variables and also enables us to analyse further the situations of people with particular identities and characteristics. This will allow us to explore collaborations with other advocacy and community groups to look more closely at subsets within the data and advocate together. Ultimately, we hope it will be a community resource. So, having had a look at the process of designing and implementing the survey, I'll turn now to the findings. We only have time to go through a few, so please do take a look through the full report, which is available via the QR code at the end of this presentation. Here, I'm just beginning to flesh out some of the implications of the findings and acknowledge that more work is needed to contextualise these in order to contribute to policy and health services development. I also want to note that there are plenty of positives for many people living in the ACT, and we acknowledge the ongoing work that people are doing in the health area. Our role is to look for ways to improve health and wellbeing, and that means looking closer at areas where there are problems and barriers. The first area of findings I'd like to look a little bit at is the area of sexual and reproductive health. One positive that we found was a relatively high uptake of long-acting reversible contraceptives in the ACT compared with Australia-wide studies. This is important because LARCs, as they're known, are more effective, take less effort, cost less over the long term, and have higher satisfaction than other kinds of contraception. Taken together, 39% of respondents in our survey used some form of LARC, which in our study we defined as including intrauterine devices, implants, injections, and vaginal rings. This 39% figure is compared with national level studies showing rates of between 11% and 24%. However, in contrast to this positive result, we found that people experiencing a range of reproductive health conditions, such as endometriosis, polycystic ovary syndrome, persistent pelvic pain, and symptoms of menopause, do not have access to satisfactory services for these conditions. For example, over half of people who had been diagnosed with or treated for polycystic ovary syndrome or endometriosis said they were dissatisfied or very dissatisfied with the healthcare for their conditions. Further analysis of open-ended responses will be useful for understanding the health needs and barriers facing people who may be experiencing these conditions. We found similarly poor experiences for people accessing care for persistent pelvic pain more generally. Persistent pelvic pain is pain below your belly button and above your legs that is present on most days, or more than 2 days of your period for people who have periods, for 6 months or more. It includes those who have endometriosis. We found it is widespread. Over a quarter of people in our survey had experienced persistent pelvic pain, and around 2/3 of those, or 17% of the survey sample as a whole, had missed work or study as a result in the last 12 months. This indicates the importance of measures such as reproductive health leave. In relation to menopause, we found that over 40% of people who had gone through menopause reported they were dissatisfied or very dissatisfied with access to support services. Open-ended responses indicated that many people did not know about options to seek help with symptoms of menopause, that they may have been constrained by stigma, sexism, and ageism, and implicitly encouraged to believe they simply needed to cope in silence. Again, further analysis will be useful to unpack this. Overall, these findings indicate the need for strategic and coordinated approaches to sexual and reproductive health, more health promotion, and access to high-quality services and support for people with reproductive health conditions. Turning now to access to primary care, we found that this too needs attention. General practitioners, or GPs, are important, and over 92% of our respondents had consulted a GP in the last 12 months. Respondents rated experiences with GPs well overall for the quality of GPs' skills, their explanations, their opportunity to ask questions, how well the doctor listened, their respect for patients' dignity and different backgrounds, and the accessibility of facilities. However, we found gaps in access to GPs, especially in relation to cost and appointment availability. A quarter of respondents rated access to GPs as only fair or poor, that is, in the bottom half on a 5-point rating scale. The problems most commonly reported were difficulty getting an appointment, 61%, and too expensive, 24%. Over 3/4 rated their access to bulk billing GPs as only fair or poor. We found that people who reported more experiences of financial stress also rated their access more poorly compared with respondents as a whole. The third area I'd like to focus on is mental health. We found that mental health needs attention. In our survey, psychological distress was widespread. 19% of respondents reported psychological distress at levels indicating they probably have a serious mental illness. This is higher than previous ACT general health surveys, but similar to some recent national studies looking at the impact of the COVID-19 pandemic. Most respondents in our survey had been diagnosed with or treated for a mental illness at some time in their lives, and 45% in the last 2 years. The most common conditions reported were anxiety, depression, and post-traumatic stress disorder. Despite widespread experiences of psychological distress and mental illness, only just over 1/3 of respondents had consulted a psychologist, counsellor, or other mental health worker in the last year. Access to mental health services was rated most poorly out of a list of 14 types of health services. And 70% of respondents in our study rated access to mental health services as only fair or poor. Mental health and access to mental health services is a common thread in concerns expressed to us across a range of areas in our work, and it is one we will be aiming to focus more on over the coming years. The final area of our findings I'd like to emphasise is that across our survey, many people reported experiences that undermine their health and well-being and also undermine their ability to improve their own health and well-being. While most people had satisfactory experiences with accessing medical care generally, significant numbers of people, more than a third, had one or more of these experiences. A third of people reported having experienced discrimination, the most common reasons for discrimination being gender, age, and appearance. However, it's important to note the underrepresentation of migrant and refugee people in our study, which also indicates that discrimination on the basis of cultural background and language background may be underrepresented also. Over a third of people reported that they only go to a doctor if they have no other option, and a quarter of people reported avoiding seeing a doctor. Over a third of people said that they were taken seriously by doctors only somewhat or not at all. And many people across our study reported experiences of gendered violence, such as reproductive coercion, sexual violence, domestic and family violence, workplace sexual harassment, and institutional violence. Just under a half of people who reported giving birth had traumatic birth experiences. These findings indicate a need for better access to gender-sensitive, equity-oriented and trauma-informed healthcare across all types of care, including primary care, different specialists, health promotion and information. That brings us to the end of the presentation. To wrap up, in the next steps with this project, we'll be doing further analysis to look at subsets of the survey sample and consider the relationship between different variables. We'll be analysing the qualitative, open-ended responses that people have given us, and we'll be looking at how we can use the survey data in our other projects. For example, understanding the needs of people who've been subjected to different kinds of violence. We'll be seeking collaborations to look deeper at the data and see how we can use it to improve health and wellbeing in the ACT. And we'll be promoting the report and encouraging people to read it, which you can do by using the QR code on the screen or by visiting our website, which is www.womensaltmatters.org.au. That's Women's Health Matters as one word with no spaces or punctuation. Or you can phone us on 02 6290 2166. Or you could email admin@womenshealthmatters.org.au. Thank you for your interest in our work, and thank you for watching, listening to, or reading this presentation.